Hello viewers, my name is Okafor Sylvia and welcome to my YouTube channel. Okay, so I am an ABA technician and I've been in this field for 3 years. This is my third year. I've been in this field since 2022. I'm a psychologist. I have a BS in psychology and I am also an ABA technician. I work with different professionals, clinicians. And today I'll be talking about an interesting topic titled Introduction to Autism. So if this is your first time here, also like myself, please click the like button and then turn up your notification for more information from your ABA technician. Okay, let's get right into it. So today I'll be talking about a very interesting topic titled Introduction to Autism. So I know many of us have heard the word autism. We've come across the word autism. You know, we've had someone say, tag or label a child, an adult, teenager, he's autistic, she's autistic. But do we really understand what autism is about? Autism, popularly known as ASD, is an acronym. Autism Spectrum Disorder. So I'm going to take it one after the other. So what is autism? Autism is a neurological condition. Neurological condition because it affects the brain. So it's a neurological condition that affects how individuals perceive, interact, and respond to the world around them. Okay? And it is a spectrum because of the diversity in it. No two autistic children are the same, even if they're twin. The severity and the level of one's intelligence might be different from another. The way one expresses their emotions, their thoughts, their feeling can be different from another. The way one is attentive to details and the way one concentrates to detail can be different from. So there are varying degrees at different level. So that's why it's a spectrum. So it is also called a disorder because it is a condition that affects normal functioning. Okay, it's a condition in which there is an abnormality of normal functioning of the body or the mind because it affects its physical, emotional, and mental functioning. So according to DSM-5, there are criteria to meet for an individual to be called an autistic patient or client. Okay, so according to DSM-5 is Diagnostic Statistics Manual 5. So it is a standard classification of mental health conditions used by clinicians. So all of the mental health conditions, be depression, anxiety, schizophrenia, delusion disorder, major depressive disorders, all of these are under the DSM-5 manual. Okay, so according to DSM-5, one of the criteria to meet to be an autistic individual is deficit in social communication. So there's usually this deficit in social emotional reciprocity whereby a child does not understand the back and forth of conversation, like when you say hello to a child and the child does not respond. For people that do not understand these children, might tag them rude, or maybe there's something wrong with his hearing or her hearing, but it's not it. They don't understand the back and forth of it. They don't understand how social greeting is done. So because some of them do not understand body language, you don't have eye contact, they're not looking at you. I mean, you just pass them and you're like, hello Daniel. This is Daniel, for example. You just say hello Daniel and there is no response. You'll be like, is he deaf, or he just do not like responding to communication, to gestures? That is not the case. The case is he does not understand the context of it. Okay, so usually for children like this, because there is also an impairment in non-verbal communication. They don't understand. Some of them do not understand non-verbal communication. So you come down to their eye level, because as an adult, you're taller than them. So they're not looking at you. They're probably looking at your chest or your tummy, And so you come down to their eye level, okay? Because some of them have poor eye gaze. They have poor eye contact. So you come down to their eye level and you be like, "Hello, Daniel. Hello, Daniel." And you can teach the child to say hello back to you. So for some children who are very good at repetition, is an advantage. For children who have echolalia, it's a plus. They can be like, "Hello, Daniel." Some will be like, "Hello, Daniel," because they do not understand how the back and forth conversation is done. So you be like, "Hello," and you be like, "Hello." So that's one of it. And another is they don't know how to express experiences. They don't know how to initiate routines, how to initiate conversations. You have to be the one doing that. And so for their parents, it can be stressful doing all of the talking. It's not like they don't want to, but they don't know how to. So you have to teach them. You have to teach an autistic child all of this skill. You have to teach them to initiate a conversation, or initiate a routine, or follow a routine. And that's why for therapists and people who have been working with children like this, when you have a child, before now, my child likes music a lot, and he'll just be like Cocomelon. From Cocomelon to I want Cocomelon. But now he knows in Cocomelon there are different rhymes, so I know the rhymes he likes. And then I'd be like, "Do you want the wheels on the bus or Christmas song?" And he'd be like, "I want Christmas song." That is him initiating what he wants. I want Cocomelon, I want Christmas song, and making a choice. Okay, because Cocomelon is all of it. So there is one that stands out. That is him initiating a conversation, and it's a big achievement for myself and for him in his social skill. Okay, so like I said, one of the criteria under deficits in social communication is an impairment in social emotional reciprocity. Not expressing the emotions and experiences. Not understanding the back and forth of communication. "Hello, how are you? Good morning, what's your name?" "My name is Daniel." And initiating conversations or initiating requests. I want to use the bathroom, I'm hungry. That's them initiating. They don't have to wait till. Yes. And secondly, like I said, is non-verbal communication. Some of them do not understand non-verbal communication. They don't understand gestures, facial expression. They have poor eye contact. Okay, they don't understand when you're angry. They don't understand when you're happy. And that's why, if you've also been in the field, you notice them. There are kids that use the wrong emotions in the wrong settings. I've been with a child who when he's hungry, no, when he's happy, he cries, and when he's sad, he laughs. Okay, that is him not functionally using his emotions adequately. Okay, and so the impairments in non-verbal communication. And lastly, on the social skill is maintaining and developing relationship. They have an impairment in that area. Some of them, individuals on the spectrum, do not know how to maintain a stable relationship. Let me give an example. Okay, let's say a new boy in class joined in during recess, during break. And let's say he joined in to play football. He likes football, but he doesn't know. Okay, let's say he likes football, and he joined in the game, and he ran to pick the ball. He saw his pets, trying to catch it and all of that, and he ran into the pitch and picked up the ball with his hands. And that is that is like a no-no in a football game. So for people who do not understand that, may just be like he's just being naughty, you know. But then he does not understand how this game is, and so he thinks that's like the best way, or he's trying to play, you know. He's trying to initiate, he's trying to make friends, he's trying to, you know, make friends, and then this happens and everybody gets angry at him and he feels bad. So you know, this can happen in other context too, other social contexts too. So they have difficulty in maintaining and developing, keeping relationships. So yes, so we'll move to the second criteria under the DSM-5. So the second criteria is restricted and repetitive pattern of behavior or activity or interest. So there are children who would hop. I've met a child who would hop 3 times in front of the class. Like he would hop 3 times in front of the class before he comes in. Okay, so that is a repetitive behavior, and he does that before class. If you try to stop him, it might ruin his day. So that is why when you're working with children on the spectrum, you should know the behavior to eliminate. Is it going to affect learning? If this behavior is not affecting learning, you know, I mean, you should just let it be. Okay, because for them it might be a calming strategy. For children who flap their hands or who shake their head, or you know, who do all of this repetitive behavior, as long as it does not affect learning, or you know, it's not in any way harmful to himself or some other person, I think we should just let it be. I have a child who would, when he's stressed, you know, he needs to calm down, he can, you know, shake his head or stand up and, you know, jump up or walk around, you know. Such children that likes to walk around, you can give them a space, maybe front or back of the class, particular place, you know, just allow them be, as long as their walking around does not hurt anybody. If they like to walk around, you can give them notes in the class, notes to share, or pen to share, or you know, just find a way of putting that into use, as long as it does not affect them or the next person. Okay, so under repetitive behavior, we have vocal and motor stereotyping. Okay, stereotypic behavior. So vocal stereotypy are non-functional words or sounds. Okay, they don't serve a purpose for you. What to them it does. It could be stimulating, or it could be calming, or you know, stereotypic behaviors are stimming behaviors. You know, they are calming strategies for children on the spectrum. You know, and everybody stims. It's just that theirs might be too repetitive, and that's why it's really obvious. Okay, so everybody have a stimming behavior. It could be nail biting, it could be drinking, you know, it could be something. Some people just like to be on that rolling chair. Yeah, I have a sister of mine. She's not on the spectrum, but then she just likes not the trampoline. She just likes the swing. Anything that feels like it, you know, that can go around or move. You know, she just likes it, but she's not on the spectrum, but she likes it. It's just one of her stimming behaviors, just one of ways of one of her coping, calming strategies. Okay, and it applies the same to autistic children. Okay, so about motor stereotypy, it can be flapping of hand, shaking of head, or like I said, special interest. Maybe they like things that spin. Some are fixated at wheels, anything wheels. Some are fixated at soft bunnies, anything soft. Okay, so yes, so for vocal stereotypy, there are children that just make some sounds. They might just like it doesn't serve any purpose for you. It might sound noisy, especially for maybe a child in a class, in a classroom, and teacher is not aware of all of these things, and she might be like, "Stop making noise, you're making noise." Okay, so that is vocal stereotypy, and because the teacher do not understand these things, she might tag the child noisy or annoying, or testing boundary, but the child is not doing that. That is one of his or her ways of coping in the classroom, especially under stress. They're still under a restricted and repetitive pattern of behavior. So some children are fixated on insisting on pattern. All right, and children like this, they have their schedule. They know that when they wake up, there is a pattern. They wake up, they dress their bed, they go to brush, and they have breakfast next. So anything that disrupts the pattern, let's say from waking up you're telling them to sweep, or you're telling them to bathe when they know they're supposed to make their bed, they can disrupt the day for them. So children like this, before you try to change their schedule, you should let them know, right? Because that is how their mind is wired. They work on schedule. So any disruption in that can bring about problem behavior, can bring about behavioral difficulty. So another is highly restricted and fixated interests. This interest could be abnormal because of the intensity of focus. Okay, it can be whales, it can be sea animals, it can be volcanoes, it can be solar. That is all they talk about, and that is all they're about. To some persons, they might sound boring, and they might sound like they're selfish, but that is all about them. That is all they are really interested in. And the next person who doesn't understand might feel like you just care about yourself, and you just like saying one thing, just like doing one thing all the time. But I mean, there's an advantage. There's another advantage to it, whereby even successful people say, if you want to go far, you stick to a thing. You stick to a thing and you do it well. So for children on the spectrum with these gifts, I see it as a gift. Children on the spectrum with these gifts are even at added advantage, because they can concentrate on a thing and accomplish it and be very good at it. We have the likes of Albert Einstein. Studies say he was on the spectrum. So because he stayed on a particular goal and made sure he achieved it, and that's the reason why we have light bulbs today. So yes, so this fixation on interest that might seem abnormal can be a plus. Okay, as long as it doesn't, it's not harmful to him or someone else, and it does not disrupt learning. Why not? So the last under repetitive behavior is hypo and hypersensitivity. Okay, so some children on the spectrum can be hypo or hypersensitive to touch, taste, sight, smell, and noise. Okay, yes, some of them have you can see my room, how bright this is. There's some children on the spectrum that can stay in a room like this because they're hyperactive, they're hypersensitive to it. Okay, they can stay in a very bright room. Why there are some kids, I have a child that one of his reinforcers is going under the sun. He can stay into the sun for 20 minutes. Then I just put him there, I go sit down, and he knows his time up. So when the time is up, we go back inside. So such a child is hypersensitive, so he needs more of this sensation. Okay, that's for sight. And for auditory, there are kids that can stay. There are kids that I don't use this level of tone with. There are children that when you're talking to them with this level, this degree of tone, it's too loud for them. So you talk in a lower voice. Or when you're playing a song, you play it at maybe at 50%. The volume of it should be at 50%, not more, not less, or even lower. And there's some kids that need more of it. So that is for auditory, and the same goes for olfactory, for hyper olfactory sensitivity. There are kids that there's a child I knew that only work with therapists that are really perfumed. They wear lots of perfume. The room has to have a lot of fragrance. If you're not wearing a lot of perfume and the room is not well fragranced, you would not stay. Okay, so same as food, there are children too that do not eat some kind of food. There are kids that would not have grains, but they would have cereal, smooth cereal. There are kids that would not have smooth cereal, they would have eba. There are kids that cannot have eba, but they can have rice. There are some that cannot have rice, but they will take cereal. It varies. The degree of it varies. That's why it's a spectrum. Why I keep saying no to autistic child is the same. Okay, so these are the criteria to meet. Under repetitive behavior and deficit in social communication, a child would have at least 2-3 criteria in this to be called an autistic child under the DSM-5 manual. So far, I hope we understand the criteria that an autistic person would meet under the DSM-5. So next, I would be going into the causes of autism. So there are different factors, but 3 factors that stands out are the genetic factor, the environmental factor, and the neurological factor. So a child with a family history of neurological disorder or autism is also likely to have autism under the genetic factor. Okay, and so usually there are times when you'd see maybe a grandfather somehow who was late many years ago had some neurological defects that wasn't diagnosed, maybe died long time ago, and it becomes recessive. Okay, the dominant and recessive gene, it becomes recessive in the father, might become dominant in the grandchild, which is presenting autism criteria. So it begs to question where and what is the cause of autism. So here it is a genetic factor, all right, but then study has also shown that there are other things, just like during pregnancy there's one of the supplement called folic acid. I'm not supposed to say this, but then it just came on my mind, and then it's one of a supplement for pregnant women, and studies have shown that women who take folic acid before and during the first trimester continuously during pregnancy have a lower, as long as it's not abused, have a lower rate of having a child born with autism, because the vitamin D family of folic acid has a way of repairing DNA damage, DNA processing. It helps to repair the neural tubes. It's a very wonderful supplement for more than child, especially for child. So that is on the genetic factor. Now, on the environmental factor, it could be exposing a child to toxin. It could be fetal syndrome, something the mother took during pregnancy, exposing the child to toxins and harmful substances like drugs, accidents, infection, and all of these things can expose the child to developing this neurological disorder. Okay, then lastly is neurological factor. So usually when children on the spectrum, during diagnosis, one of the criteria is the MRI scan. So usually you find out that the cerebellum, the amygdala and frontal lobe is different from a neurotypical child. So the brain of a neurodivergent child is different from that of a neurotypical child. The amygdala is responsible for emotion, fear, disgust, aggression. So the shape of it is different from that of a neurotypical child, just like the cerebellum that also controls motor functioning. So yes, because movement, everything that has to do with movement, physical motor functioning, it's usually with the frontal lobe and the cerebellum. Okay, so the frontal lobe helps with organization, it's the seat of consciousness. It helps with organization, it helps with sequencing, it helps with carrying everyday functional activity, it helps with planning, organization, carrying out tasks. So this is where most children on the spectrum have difficulty in. They have difficulty in doing their day-to-day self-care routine, social routine, social skill, communication. So from what we've been saying so far, there is no one cause or one factor that causes autism. So there are different factors. Outside the environmental, neurological, and genetic factor, there are other factors like low birth weight. There are other factors like age factor. Studies have been said that for women who have their first child above 35 and for men who have their first child above 40 are susceptible to having a child with autism. Okay, so their age factor, substance abuse, there are other factors too that can predispose a child to having these criteria. Okay, so usually they are noticeable at 2-3. Usually these criteria are noticeable at 2-3. There are kids that usually have words and they start losing it. Okay, so next I'll be going to autism as a spectrum under autism. So the spectrum under autism there are 3 spectrum, which is level 1 to 3. And level 1 is mild, level 2 is moderate, and level 3 is severe. So individuals under the level 1 mild autism, these are people, we see them every day, okay, but then they require little assistance in their daily functioning. These are individuals that can carry out simple tasks, but then there's a noticeable level of social communication, social impairment. Okay, now the level 2, which is the moderate level, individuals under the moderate level require a substantial amount of help in their daily functioning and communication. There is an impairment in their communication. And the last level, which is the severe, these are individuals that require help in every area of their life. You teach them to say good morning, you teach them to eat, you teach them to wear their dress, you teach them to understand the word stop, wait, come, keep this on the table. You teach them every skill. These ones on this level require all the help they can need, all the help they can get rather. So and these are the ones that really need early intervention. Okay. So that is for the spectrum. So we have level 1 to 3, mild, moderate, severe autistic individual. So next I'll be talking about co-occurring conditions, and co-occurring conditions can also be tagged comorbidities. Okay, when there is more than 2 obvious conditions, when there is obviously more than 1 disorder, and more than 1 2, because you see children presenting ASD, presenting autism, ADHD, and even Down syndrome. Okay, but maybe ASD might be, maybe autism might be a level 1 or 2, maybe a level 1, and attention deficit hyperactivity disorder. Maybe the child might have an impairment in attention deficit, in paying attention to details, but not hyperactive, and Down syndrome. So the comorbidity that comes with the co-occurring conditions, comorbidity that comes with children on the spectrum includes ADHD, attention deficit hyperactivity disorder, intellectual disability. So under intellectual disability, we have dyslexia, dysgraphia, and even gifted too can also be on the spectrum, the likes of the hyperlexia. And we also have anxiety, depression, though this is common amongst teenagers and adults. It's prevalent amongst teenagers and adults. And then epilepsy. These are co-occurring condition of comorbidity that comes with autism. So next is diagnosis. So far we've talked about comorbidity, we've talked about causes, and we've talked about criteria. So now we want to know the diagnosis and early interventions that are best for children presenting symptoms, and children who meet the criteria for being an autistic child. So let's get into it. So early interventions, actually keys to early intervention diagnosis, actually keys that helps to improve the life of children living with autism. So speaking about early interventions, one of it that I've seen that have helped children across boards is ABA therapy, speech therapy, occupational therapy, social emotional skill therapy.